Thanks, everybody. So I'm going to give you a slightly briefer overview. Can everybody in the room see my slide deck? So I'm going to just talk about mantle cell lymphoma. So mantle cell, obviously not as common as diffuse large B-cell lymphoma, but has some of its own sort of unique challenges around the management of the CAR T product that's available for mantle cell lymphoma and the management of the patients moving into CAR T cell therapy. Now, Sridhar talked about sort of identification of risk and also bridging strategies and actually the fall off of patients before CAR T, and it's just important to sort of think ahead a little bit with any patient that you might manage, and I'll touch on some of that. So here's just a kind of overview as an algorithm of the management of mantle cell lymphoma that exists at the moment. This actually was a review that was written really with kind of both the US and the European availability in mind. But in terms of the European availability, frontline therapy is typically immunochemotherapy, and obviously the intensity varies according to people's age and fitness. Younger people have a cytarabine and rituximab induction and an autologous transplant and rituximab maintenance. Older patients, those with more comorbidities, tend to have rituximab in addition to chemotherapy, and the most commonly used regimes we use are bendamustine-based treatment and CHOP-based treatment, often with maintenance rituximab following that. And the median duration of remission lasts with older patients about 4 to 5 years on average, in younger patients anywhere between 7 to 10 years. But all patients will inevitably at some point relapse and will receive ibrutinib at first relapse based on some data I'm going to show you, but also based on the NICE approval. So the management pretty much in the UK universally is to use ibrutinib at first relapse because of its availability and its funding there. But one of the key things then to think at that time point and beyond is, are the patients CAR T cell suitable or not? And if they are, then consider referring patients early for discussion about CAR T cell therapy. And the product that's available is brexacaptogene autoleucel, or Brexicel, or Tecartus, you'll often hear it called, which is the sort of trade name. Allogeneic stem cell transplant has generally, by international consensus guidance, been sort of relegated to the post-CAR T cell setting. And I'm not specifically going to talk about allogeneic transplant today. And then sort of beyond CAR T cell therapy is a space of what I would describe as unmet need, but also an area of ongoing development and investigation. So I mentioned to you that ibrutinib is available at first relapse, and this is primarily the reason why. I'm just going to spend a few moments on BTK inhibitors. I hopefully won't feel like I'm laboring the point too much, but it's really relevant and important. So you can see here, this is a pooled analysis from a range of clinical trials where patients received ibrutinib monotherapy, and these patients were then subsequently analysed, pulled together and subsequently analysed and managed and assessed according to survival, according to the number of lines of therapy they'd had previously. And you can see here that if you receive ibrutinib at first relapse, as opposed to subsequent relapses, so second line rather than third, fourth, fifth, etc., you can see there's a substantially improved progression-free survival. So more patients achieve a remission, more patients achieve a deeper remission, and the remissions generally last for longer. And hence the sort of idea and the hypothesis around utilising ibrutinib then. And of course, the overall survival analysis is a bit harder to interpret because you're dealing with two slightly different populations at different time courses in their disease. But nonetheless, you can see that if you use ibrutinib earlier, you gain probably more from it. And this is the overall response data demonstrating that if you use ibrutinib at first relapse, you obtain complete remissions in 36% of patients, whereas later lines of therapy, it's down just over 20%. And numerically, there's a substantial difference in overall response rate. If you happen to achieve a complete remission, probably won't surprise any of you that your length of remission, duration of remission, so for example, your progression-free survival is substantially longer as well. So use ibrutinib earlier, you get better, deeper responses, and they last longer. but not everybody is in sort of that camp where you can be talking about use of ibrutinib for 3, 4, 5, 6 years, patients achieving long remissions. That's certainly not the case in patients who have so-called high-risk mantle cell lymphoma. And those are the definitions vary in the literature, but the three key take-home messages are: if you have blastoid morphology, if you have a p53 deletion or mutation primarily, or if you have a highly proliferative disease as measured by something called your Ki67, which you can check on the biopsies. If you have any one of those three features, then your remission length on ibrutinib is between sort of 4 to 5 months. And the point there is that these patients sort of are progressing almost in front of your eyes, and you need to be thinking ahead in those instances. If you take the analysis of those 370 patients with ibrutinib across the board, and you look at those subgroups and also those with a high simplified MIPI, so it's an International Mantle Cell Lymphoma Prognostic Index. If you look at those three groups, you can see that the median progression-free survival in each of those groups is between 4 to 6 months, with overall response rates of 50 to 55%. So this is not like CLL, where everybody responds to a BTK inhibitor and it often works for many years. This is a situation where these patients, so about a third of mantle cell lymphoma patients kind of cumulatively, have at least one high-risk feature and will have limited response rates, i.e. responses just over 50%. But of course, that's a lot of patients not responding to ibrutinib. And then the median PFS of being only, about 6 months. Well, so of course, many of your patients are progressing before that 6-month time period. So I think what we've come to learn with this experience, and with certainly the early CAR T-cell experience in mantle cell lymphoma, is that these patients need to be identified early and referred early and considered for CAR T-cell therapy, before they progress on a BTK inhibitor. And that, in essence, is the idea behind the recent addendum to the British Society of Haematology Mantle Cell Lymphoma guidelines. It's been published only a couple of months ago, and I won't go through all this, but it's open access, so do go away and look at it. That the point here is that at first relapse, you should be asking the question: is somebody suitable for CAR T cell therapy subsequently? Number one, and number two, what's their risk of progressing through a BTK inhibitor, and shall we be basically looking to refer them early and consider CAR T cell therapy early? Because actually, we're going to see at ASH this year data from the UK. I can't sort of share all the slides with you at the moment, but data from the UK suggesting really quite a high fall off of patients from assessment in the NCCP panel through to actually achievement of delivery of CAR T-cell therapy at mantle cell lymphoma. So this disease, when it gets to this point, post-CAR T-cell therapy is as aggressive as diffuse large B-cell lymphoma, and it should be managed as an aggressive disease, and hence why the only advantage we have ahead of the disease is we can sort of think ahead of it. That's broadly the recommendation. And of course, what that includes is people actually rebiopsying patients at relapse to look for those high-risk genomic histological features and immunohistochemistry features, because if you don't rebiopsy, you may miss these cases. And one of the risks, I think, here is that we put somebody on ibrutinib thinking it's going to just work for ages and sort of forget about them a little bit, and then all of a sudden they're progressing through it and time's against you. So that's a kind of really key point. So that's the kind of bit of the talking about BTK inhibitors before CAR T-cell therapy. The CAR T-cell product that we have available now is, as I mentioned, is called Tecartus. It's based on the Zuma-2 study. So this is a pivotal study, Kite Gilead sponsored, run primarily in the US, in a high risk but quite heavily selected group of mantle cell lymphoma patients. So patients were enrolled having received between 1 and 5 prior lines of therapy. Bridging in this study was optional, so you could either give some steroid alone or continue the BTK inhibitor that the patients were on. They then received standard conditioning chemotherapy, so fludarabine, cyclophosphamide. Then the CAR T cell product. It's slightly different to axi-cel, and there's an additional step to basically remove peripheral blood B cells, because obviously the theoretical additional risk of circulating mantle cell lymphoma cells in the peripheral blood, kind of you see that obviously more commonly than you do in DLBCL. So that's why the product is very slightly different to axi-cel, but in essence it's very, very similar. And then patients were assessed and followed up. The primary endpoint of the study was overall response rate and a number of key secondary endpoints. So a smaller study than the studies we've seen in DLBCL, obviously mantle cell lymphoma being that much more uncommon. 74 patients were leukapheresed. Most people received conditioning chemotherapy, and the majority received the CAR T product. So actually only a fall off of 6 patients in this study, sort of speaking to some of the selectivity within some of these initial phase 2 studies that we see. The median delivery from leukapheresis to delivery of CAR T cell therapy was relatively short, at I think 16 days. And as I said, manufacture was successful in nearly all patients. Here's the baseline characteristics of the study population. So generally a younger patient group, so median age of 65, fit with an ECOG of 0 to 1, but with a number of patients with quite high risk histological features, so high Ki67, a number of patients with a P53 mutation, advanced stage disease in the majority. And the population that was studied was primarily those that have received immunochemotherapy, so a CD20 antibody alongside chemotherapy, then subsequently a BTK inhibitor. All patients have been exposed to a BTK inhibitor, and a median of 3 prior lines. So it may well be the case that a number of these patients have had additional treatment as well. Certainly in the US, there's quite a lot of use of drugs like lenalidomide, for example. Bortezomib is also a licensed and approved drug. So there are other agents that can sometimes be used, as well as obviously more than one chemotherapy agent. So median prior lines of 3, pretty heavily pre-treated group of patients. And here's the overall response rate by independent assessment. You can see that the overall response rate over 90% in this patient pool, with over two-thirds of patients, so 68% of patients achieving a complete remission. In the intention, so when you include the patients who drop off from the initial treatment, the overall response rate is still 84% in this study, CR rate of 62%. And these responses were durable, as I will show you. So here is the recent update of the progression-free survival published in the JCO this year. So this is update with effectively 3 years or so follow-up. And I suppose the key thing here is that patients generally had a duration of response that seemed to be relatively agnostic to some of the higher risk features that I've talked about. So I suppose the point here is that if you can get these high risk patients to CAR T, it may well be the case that they actually respond well and gain durable clinical benefit from that therapy. Now, those subgroups are pretty small. Some of them are very much groups where I would say the data is hypothesis generating, and we need to see more data in those groups of patients. But nonetheless, what we have at the moment is pretty encouraging. There are very few relapses that were late. So beyond the 2-year time point post-infusion, there are only actually 3 relapses that were seen. And you can see here, according to that Kaplan-Meier curve, if you just focus on those who obtain the complete remission, so it's just over 2/3 of patients, you can see that the median progression-free survival has just been reached at 4 years. Now, probably too early to say patients are potentially cured because some late relapses are occurring, but it's a possibility, and certainly a number of these patients are getting very long remissions. One of the issues here, and obviously we've just touched upon some of the toxicity issues with CAR T cell therapy. One of the issues with this particular product is that it is pretty toxic. So in this study, 15% of patients had grade 3 or more cytokine release syndrome, and really notably, a third of patients experienced grade 3 or more neurological events. Now, I'm not going to go over all of the detail on this slide, but the CRS events are generally early. You see them at a median of 3 days. Typical manifestations include fever, hypotension, hypoxia in about a third of patients, chills, tachycardia, etc. There's effectively a sort of myriad of symptoms that you sometimes see. And the median duration of CRS was about 10 days, but of course the severity wouldn't be the same during those 10 days. The neurological events that tend to occur earlier. Nearly 70% of patients who receive this CAR T product have neurological events. So it is pretty common to see neurological toxicity with Tecartus. The median onset is about 5 days later than CRS, and it lasts a bit longer as well, typically. But you do also sometimes see some cases where neurological events can actually be fairly long lasting. You can see here the range in CRS here is up to 50 days, whereas the range of neurological events here, of course, some of these might be quite subtle neurological events, but the upper range there is 567 days. Just the point to make is that some of these take longer to resolve than the CRS, basically. Now, I'm not going to talk specifically on toxicity management in this talk because this is being covered later on today, but this product probably is the most toxic product that is available and used at present. And I think, that's certainly the experience of those around the country who've used it so far. Nonetheless, there were no grade 5 adverse reactions related to CRS or neurological events, so there were no deaths related to either of those two. And there were 3 deaths on the study. I think a couple were due to infection, but the TRM is in the study population was about 4 to 5%. Now, one of the key questions here, of course, is can you recapitulate the data from the ZUMA-2 study in the so-called real world? This is the largest data set we have so far from the US Lymphoma Consortium. And this is sort of initial, fairly short follow-up data looking at responses. And what you can see here with this forest plot is that again, responses are high in the kind of 90% range. And again, CR rates in the kind of 70% range again, with no clear differentiating factors associated with higher or lower response rates. So I suppose, one of the key things here is patients with high risk disease seem to be getting response rates similar to the overall population. The other intriguing thing here is obviously the ZUMA-2 eligibility was fairly tight, and actually a lot of patients treated outside of clinical trials may have been sort of ineligible for the clinical trial for one reason or another, but actually response rates in this population were the same, whether they were sort of eligible for ZUMA-2 or not, which, is encouraging, but I think we need to see more data. Just briefly, I wanted to touch upon sort of what agents could be used as bridging strategies or ones to avoid. And I really want to just mention that there's data from the ZUMA-2 study to suggest that if you use bendamustine before you apheresis cells in a reasonably close time point to the apheresis, you can, in theory, affect the efficacy of the CAR T cells in terms of looking at factors such as area under the curve, peak CAR T cell response. So the PK analysis that are done from the ZUMA-2 study do suggest that you should minimize the use of bendamustine prior to apheresis. And obviously that's a kind of an issue potentially in DLBCL where polar BR is used, but some of these patients may be naive to bendamustine. And if you are going to use it, you really want to do it post CAR T cell apheresis. There are a couple of slides on liso-cel. This is not licensed at the moment, so I really show this for interest. A similar study to the ZUMA-2 study has been performed in a similar patient population. We'll talk more about the toxicity profiles of the different agents in a later talk, but liso-cel, broadly speaking, is much better tolerated and has significantly less neurotoxicity particularly. And the 32 patients that have been studied so far with mantle cell lymphoma have demonstrated, again, response rates in the same kind of ballpark. So 84% overall response rate, 66% complete remission rates in the Transcend study. This is a subpopulation of the overall Transcend study. So it's not the largest patient pool by any means, but hopefully we'll see longer follow-up with this data set in the future. And it's possible that this product will at some point become licensed in mantle cell lymphoma, but I think we need more data. So I just want to finish really highlighting the eligibility for CAR T cell therapy in mantle cell lymphoma at the moment. So this is the NCCP eligibility, and you can see here that you have to have mantle cell lymphoma. There is no upper age limit, but this is obviously discretionary according to both CAR T cell center and also to those referring. But of course, you know, fundamentally the CAR T center have to be happy to deliver the treatment. They've got to have had chemotherapy, a CD20 antibody, and a BTK inhibitor at the moment. You can have had a prior allograft. It's not a specific exclusion, but you can't have things like active GVHD, etc. You've got to have an ECOG of 0 to 1 at assessment. But if you happen to have sort of deteriorated to an ECOG of 2 at infusion, that's considered acceptable. You have to have no active current CNS mantle cell lymphoma, but you can have had prior CNS mantle cell lymphoma. That's not a specific exclusion as long as it's not active at that time point. And then the eligibility in terms of comorbidities is very sort of discretionary, but organ function requires reasonable creatinine clearance and effectively a pretty normal echo. Yeah, some of the sort of criteria that we're pretty used to when it comes to autologous stem cell transplant. But I think one of the key things here is once these patients get through the panel, then obviously moving as quickly as possible to therapy is important. But the key in all of this is early identification of patients at risk of BTK failure. And I will stop talking there, and I'm happy to take questions.